but we have many other types. For example, I said about mesenchymal. For example, in stomach, sometimes we have tumor in the epithelium, in the mucosa, we call it adenocarcinoma, okay? Sometimes we have tumor in the muscular tissue, and we call it, for example, leiomyosarcoma, okay? In any part, or sometimes in the vessel, we have angiosarcoma. Any part of cells and any part of body can be mutated and finally can show the
mutated from environmental factors.
Yes. All both environmental and genetical. Both factors are important and they act together. Now about host defense against tumor and tumor immunity. Tumor cells can be recognized by immune system as non-self and destroyed. Anti-tumor activity is mediated by predominantly cell-mediated mechanisms. Tumor antigens are presented on the cell surface by MHC class I molecules and are recognized by cytotoxic lymphocytes that are CD8 positive. In immunocompetent patients, tumors may avoid the immune system by several mechanisms, including selective outgrowth of antigen-negative variant. Okay, some tumors may be antigen-negative, so the cytotoxic lymphocytes can find them. Loss or reduced expression of histocompatibility antigens. Immunosuppression mediated by secretion of some factors by tumor, like TGF-beta. Tumors can make and secrete some cytokines like TGF-beta, and they can make immunosuppression in patients. And also we have some immunosuppressed patients. In the immunosuppressed patients have an increased risk for development of cancers. Okay, now a few slides about the clinical aspects of neoplasia. Effects of tumor on host. Location is very crucial, is very important in both benign and malignant tumor. What does it mean? For example, a very small adenoma. Adenoma is a benign tumor of any part. For example, here I say about pituitary adenoma. Okay, a small pituitary adenoma can compress and destroy the surrounding normal gland, and starting the symptoms of hypopituitarism. Okay, so with a very small benign tumor, but in an important site, we have many signs and symptoms. Okay, and we find these types of tumors very soon because the patients have impaired blood pressure, impairment in their blood glucose, and many other features, for example, hypothyroidism or hyperthyroidism, and some other sign and symptom like this. Or a very small leiomyoma. Leiomyoma is a benign tumor of muscles, smooth muscles, okay, of smooth muscles. But when this is in the wall of renal artery is very important site, and when a very small benign tumor find here, it can compress the blood supply, leading to renal ischemia, and after that we have hypertension. But sometimes we have very large leiomyoma in the uterus. But patients only experience, for example, a little abnormal uterine bleeding. Sometimes we found some leiomyoma, for example, 20 centimeters or sometimes larger. And patients say that I had only a little AUB, abnormal uterine bleeding. But if this is in renal artery or a in an important site, in crucial location, we have many signs and symptoms. So the location of tumor is very important for finding them and for their signs and symptoms. Cancer cachexia. You know what's the meaning of cachexia?
Fever, due to fever, the loss of weight.
Weight loss.
Weight loss due to fever.
Yes, yes. Many cancer patients suffer progressive loss of body fat and lean body mass, accompanied by profound weakness, anorexia. What's anorexia?
It's like a loss of appetite.
Loss of appetite, yes, and anemia. All of this condition referred to as cachexia. And sometimes we see that these patients are very, very thin, especially in the later age and later stage of malignancy. Cachexia results from the action of soluble factors such as cytokine produced by the tumor and the host, rather than reduced for food intake. TNF. TNF produced by macrophages in response to tumor cells or by the tumor cells themselves mediated cachexia. TNF suppress appetite and inhibit the action of lipoprotein lipase, inhibiting the release of free fatty acid from lipoproteins. Now about paraneoplastic syndrome. Do you know anything about paraneoplastic syndrome? Sometimes in patients we have some signs and symptoms that we can't explain them by the location of tumor and by the tumor by self, by own, okay? There are some systemic symptoms that cannot be explained by tumor local and distant spread or metastasis or by hormone appropriate to the tissue. They appear in about 10 to 50% of patients with cancer. For example, I think I had a table, yes. For example, Cushing syndrome. Cushing syndrome patients have moon face, a very round face, and accumulation of fat in their posterior neck area. And also they have very thin limbs and very fat abdomen. This syndrome is Cushing syndrome. Cushing syndrome sometimes is seen in small cell carcinoma of lung, okay, or in pancreatic carcinoma or neural tumor. For example, in a small cell carcinoma of lung, we can't explain the fatness of abdomen or the moon face or accumulation of this fatty tissue in the neck. Okay, we can't explain. But we see that these syndrome are related to these types of tumor, and we call them paraneoplastic syndromes. Okay, and this is because of adrenocorticotropic hormone or adrenocorticotropic hormone like substance that this tumor can produce. Or sometime in a small cell carcinoma of lung or intracranial neoplasm, we have syndrome of inappropriate antidiuretic hormone secretion. Sometimes we have hypercalcemia, okay, in some tumor, for example, squamous cell carcinoma of lung, breast carcinoma, renal carcinoma, ovarian carcinoma. The patients show, for example, in their blood test, high level of calcium, and sometimes we don't know why. We don't know why this type of tumor show hypercalcemia. Sometimes hypoglycemia. Hypoglycemia, for example, in fibrosarcoma. Fibrosarcoma is a type of malignant mesenchymal tumor of fibroblastic cells and fibroblastic tissue. In fibrosarcoma, we have hypoglycemia, maybe because insulin or insulin-like factors that fibrosarcoma can produce. Okay, so by the location of the tumor and by the metastasis of this tumor, we can't explain the cause of paraneoplastic syndrome. The most common such syndrome are hypercalcemia, Cushing syndrome, and non-bacterial thrombotic endocarditis. The neoplasms most often associated with paraneoplastic syndrome are lung carcinoma, as I said, especially small cell carcinoma of lung, breast carcinoma, and also hematologic malignancy like AML. Now about grading and staging of the tumors.
Ma'am, when we have cancer, the cancerous cells are still able to perform.
May be classified as grade 1, 2, 3, or 4 in order to increasing anaplasia. Anaplasia is any change in the shape of the nucleus and in the shape of tumoral cells, as I said yesterday. In some tumoral cells, we have many change, many pleomorphism, bizarre shape in the nucleus, and we say that this tumor have anaplasia, or we say that this tumor is anaplastic, for example. But some tumors show well differentiation, okay? So we say some tumors are well differentiated and some tumors are poorly differentiated, or some tumors are undifferentiated. This differentiation means that this tumor seems to the normal tissue or no. Okay. For example, in the squamous cells, squamous cell carcinoma, some squamous cell carcinoma, the cells are seems to the normal cells, okay? They are well differentiated, but sometimes they are very poorly differentiated. They have very different shape with anaplasia and pleomorphism, and sometimes we can't understand that this is from squamous cells, you know? By only microscopic examination, we find that this is an anaplastic tumor with pleomorphism, and this is very poorly differentiated, and we can't understand that this is from a squamous origin or from, for example, a gland origin. And sometimes in this condition, we use immunohistochemistry, and sometimes we use molecular tests, PCR tests for finding that the origin of this tumor is which kind of our body cells, okay? Because the treatment and the drugs are different. For example, the chemotherapy for a squamous cell carcinoma is different from chemotherapy for adenocarcinoma or lymphoma. So this differentiation and grading of tumors is very important for treatment and for exact and correct diagnosis. Now about staging. Staging is based on the size of primary lesion, extent of excrete to regional lymph node, and presence or absence of metastasis. So, grading is histological finding. By microscope examination, we grade the tumor. For example, for very bad shape and bizarre shape and anaplastic shape tumor, we say that this tumor has high grade. But about a stage, we say on only the size of tumor, lymph node involvement, and metastasis. So we use a staging system of TNM, T for size, N for lymph node, and M for metastasis. We use from TNM staging system, or some university and some hospital use other staging system. For example, we said AGCS staging system. Now about laboratory diagnosis of cancers. We use from morphologic methods. Several sampling approaches are available, including excision or biopsy of tumor, fine needle aspiration, that is a kind of cytology examination, and cytologic smears. Many information that we have about tumor is because of the excision of tumor and a microscopic examination of the slides, and all by biopsy of the tumor. And sometimes for some information we use only cytologic smear. For example, this is a cytologic smear. For example, pap smear. Pap smear used for seeing and for finding some information about the squamous epithelium of uterine cervix. We can use this way for seeing the nuclei and cytoplasm of the squamous epithelium, and sometime in this way we can find the dysplasia of the cells, and we can find the neoplasia and malignancy very soon by this way. Immunohistochemistry and phagocytometry studies help in the diagnosis and classification of tumors because distinct protein expression patterns define different entities. Also, we have some tumor markers in laboratory tests. Biochemical assay for tumor-associated enzymes, hormones, and other tumor markers in the blood cannot be utilized for definitive diagnosis of cancer. However, they can be useful for a screening test, and in some instances have utility in quantitating the response to therapy and detecting disease recurrence. So from these tumor markers, we have many tumor markers. For example, PSA, prostate-specific antigen, is very useful antigen for prostatic carcinoma, but not for definite diagnosis. This is a screening, and when we see that PSA level is high in a patient's level, we start to taking some biopsy sample from the prostate tissue for finding a carcinoma, because sometimes infections and other inflammation can cause this high level of this antigen and prostate-specific antigen in the serum level. As I said, PSA for screening of prostate cancer and for detecting residual disease and recurrence after surgery and after treatment. CEA produced by carcinoma of colon, pancreas, stomach, and breast, also used for follow-up of the patient, for example, with colon cancer. Alpha-fetoprotein produced by hepatocellular carcinoma, yolk sac tumor, and embryonal carcinoma. Unfortunately, like PSA, these markers can be produced in variety of non-neoplastic conditions. So CEA and alpha-fetoprotein assay lack both specificity and sensitivity required for the early detection of cancers. As with PSA screening, they are still particularly useful in the detection of recurrence after excision. And now about molecular diagnosis. Molecular study nowadays used for diagnosis of malignancy and for some information about prognosis and behavior of tumor. For example, in diagnosis, PCR-based detection, PCR is kind of molecular study, of BCR-ABL transcripts provide the molecular diagnosis of a kind of leukemia, chronic myeloid leukemia, or CML. CML has this type of translocation, and if we find this BCR-ABL translocation, we can say that this patient have chronic myeloid leukemia exactly. And about prognosis and behavior, FISH and PCR methods can be used to detect amplification of oncogenes such as HER2-neu and NMIC, which provide prognostic and therapeutic information for breast cancers and neuroblastoma.
Ma'am,
इसको ट्रांसक्रिप्ट करने
the
इसको
BCR18 is the mutated gene in myeloid leukemia.
Yes.
महिला पैटर्न
And we can find this by PCR and molecular study. We can use the molecular study for detection of minimal residual disease, detection of PCR ABL transcripts by PCR assay give a measure of residual disease in patients treated for CML and chronic myeloid leukemia. Sometimes for diagnosis of hereditary predisposition to cancer, germline mutation of several tumor suppressor genes such as BRCA1 or BRCA2 increase a patient's risk for development of certain types of cancer. Sometimes in this patient, we can make some prophylactic therapy, prophylactic surgery. When a patient have this type of mutation, we can do some prophylactic surgery for prophylaxis of any malignancy. Sometimes we use for therapeutic decision making. Therapies that directly target a specific mutation are increasingly being developed, and so detection of such mutation in a tumor can guide the development of targeted therapy. Now we have targeted therapy in many tumors, and they act very well in curing the malignancy. Clinical trials have shown that lung cancer with ALK mutations respond to ALK inhibitors. ALK inhibitors are some types of chemotherapy drugs, whereas other lung cancer don't respond to this type of drugs. So in the lung cancer, we can find the ALK mutation by PCR study, by molecular study for using this ALK inhibitor or no. Leading to recent FDA approval of ALK inhibitor for use in patients with ALK mutated lung cancer. Now we have some drugs for this ALK mutated lung cancer.